Our next speaker is Professor Jeremy Su. He holds a doctorate in clinical surgery, and he's a fellow of Royal Australasian College, and as well as a fellowship in American College of Surgeons. He's going to enlighten us about state-based trauma system and improvements from New South Wales. Over to you, Dr. Jeremy.
While the slides are coming up, I just want to thank the organisers for the invitation to come and speak. I'd like to thank the chairs for holding this session and hanging around. I'd like to thank everyone else in the audience for staying around. I know it's late in the afternoon. This is the last talk, so I know I'm standing in your way, like to tea. But I'm really grateful for the opportunity to share some of the information that we have. And I also have to say, we were privileged last year as part of the Australian and New Zealand Association for the Surgery of Trauma to actually come and work with the Trauma Secretariat and the Ministry. Dr. Gunawardena and Dr. Jagoda and colleagues, we were able to visit various hospitals and actually around the country, and I'm excited to see the developments from that. So I was asked to talk about our trauma system in New South Wales, and I don't really have any disclosures that are relevant, but it's important to understand the definition of a trauma system, which is really a coordinated effort in a defined geographic area that delivers the full range of care to all injured patients and integrates with the local public health system. And that's a lot of words, but really the key things from there is that it's coordinated, you have a defined area, and it has to work with the resources that exist within your area. And that's a key part of the system. For us in New South Wales, this is the most populous state. It occupies sort of the southeastern part of Australia. It has about several million people, about 8 million people, and 63% of the population actually lives in my home city of Sydney. The landmass, though, measures about 800,000 square kilometres, and I promise you that's not all just Sydney. So you can see that the population distribution is a lot in one small area, city, and then a proportion of the population spread over a very large area. Sydney itself is the largest city in Australia. The population is just over 5 million, and it's a major commercial, artistic and tourism centre. And I would welcome and encourage all of you to come and visit if you have time. It's a beautiful city and with lots of things to do. The particular area where I work is Western Sydney, and the population is about 1 million. It's probably a little bit more, and there's been continuous growth because it is the central part of Sydney. It's where there's a large migrant population, a lower socioeconomic group residing in Sydney. It's not the harbour side part that you'll see on tourist brochures and advertisements. The hospital itself was built in 1978. It says it's 975 beds, but that's variable. Now it's probably a lot less. We're a teaching hospital, quaternary referral hospital. It's right in the geographical centre of Sydney, and we're the equivalent of a level 1 trauma centre. So with regards to the system, you can see the state of New South Wales, again, is a very large geographical area, and really all of those, if you can see them, that sort of little rectangle is Sydney and where all the major trauma centres are. So there are no major trauma centres really outside, except for one, which is about 2 hours north of Sydney. All the rest of the major trauma centres are concentrated in Sydney. There are none outside that. The trauma centre designation, you can see there that it's, again, mostly distributed within metropolitan Sydney with regards to the major trauma centres. The regional trauma centres are then distributed further out. As you've heard before today, the key mantra about trauma is to get the right patient to the right place at the right time. And I think these are actually probably the most important aspects of a trauma system. You have to have good data collection. You can't start a trauma system or develop a trauma system if you don't know what you don't know. If you can't tell someone what your actual mortality is across your hospitals, you cannot have a trauma system. You need to have the right patient at the right place in the right time. That means you need to have trauma centre designation. It's well known that patients do better in trauma centres. You must have an integrated, inclusive system, and you could make arguments and we can have discussions about inclusive versus exclusive systems. However, I guess the data would suggest that an inclusive system utilises all the hospitals within your existing system to provide adequate trauma care, and I think that's a more effective and more efficient way of managing that. Of key importance is that you need to have a pre-hospital system of triage and bypass, so getting the patient to the right institution, particularly for an inclusive system. You don't want to bring them all to the one hospital. It's actually better off bringing the more severely injured to the major trauma centre. The less severely injured can go to the local hospital. The other component is the quality improvement and monitoring, because once you have the data, you're able to actually look at the system, how it's performing, and how do you improve it, right? So it's really important to measure outcomes when you're developing a system. And I put in brackets this education and prevention because, in my opinion, the education will continue. And this is one of the observations that we made when we visited Sri Lanka last year. From a clinical perspective, the individual clinicians in the hospital, in the resus bay that we met, are very sound clinically. I have no doubts whatsoever that everyone is actually very well trained and able to look after an injured patient. However, the part where it fails is the system itself. That's the challenge. But education is an ongoing issue as well as prevention. And once you have a system set up, you can actually pursue that, those two components. In New South Wales, we developed the Institute of Trauma and Injury Management called ITEM. The history of ITEM actually starts in 1985, and this will be too small for you guys down the back to see, but basically my hospital at Westmead was the first hospital to start a trauma data registry in 1985. That was the start of trauma kind of system development. And then through that, over the next sort of 10 years, the state determined a plan and then implemented pre-hospital type triage to centres. And we established back in 2010 a formalised bypass protocol, what we called the T1 protocol, where ambulances would take severely injured patients up to 60 minutes transport time. So not to the closest hospital, they may drive past a hospital, but they are allowed to go 60 minutes to the trauma centre because we knew that outcomes were improved. You can see that the system continues to change and evolve, and we actually had then the, most recently, the essential New South Wales model of care for the various hospitals. This diagram really captures what a system involves, and you can see around the outside it's data collection, right? Data collection is the fundamental part of developing a trauma system. The trauma system involves all phases of care, so that's before the injury, at the time of injury, while the patient's in hospital, and then after the patient's left hospital. And so all of those components, you can see it's a circular process, right? You can look at each component in that system and then implement improvements in each part of those phases. So what have we learnt? Well, the state puts out a combined major trauma report, because we have a state-based registry. So every trauma hospital in New South Wales contributes to the state registry. And so a report comes out. The most recent is 2022-2023. And there are some key findings in there. You can see, and I don't know whether it was reflected here in Sri Lanka, but our volume kind of dipped during COVID of severely injured patients. And it started to creep back up as people become, fall back into old habits and start doing things like speeding and alcohol-related violence and the such. But you can see that actual change there. The mortality, when you look at the number of major trauma or cases, this is actually not the mortality, but actually where the patients, the severely injured patients, were treated. And you can see, like that dark blue line, you can see that by far and away, the vast majority of the major trauma patients within the state were treated at the equivalent of a level 1 trauma centre. And that's exactly what you want, right? You don't want your severely injured patients to be treated at lower level centres. So it just demonstrates then that actually we're performing pretty well in terms of getting the right patient to the right place. The mortality trends you can see has stayed pretty static through the previous 5 years. The mortality in the major trauma centres stayed around 10%. Remember, this is not for every patient. This is ISS greater than 12 for that. So this is a more severely injured cohort. The interesting thing is that we actually did a study that was published looking at the benchmarking of all hospitals within New South Wales. That's both regional trauma centres and major trauma centres. It was a hierarchical logistic regression model where we took hospital level characteristics, such as if it was a major trauma centre or a regional trauma centre, and we took the injury patient level characteristics and then risk adjusted the outcomes. About 14,000 patients, 12,500 patients were from the major trauma centres, and the regional trauma centres had the remainder. As you would expect, the predominant, it reflected exactly what we know. Mostly males get injured. For us, the mean age was 55. We have a lot of falls. And you don't need to understand this curve entirely, other than the fact that the blue lines are the major trauma centres, and the red lines are the regional trauma centres. And basically that horizontal line is, the relative risk of dying. And you can see that nearly all the blue lines, all the major trauma centres, are towards this end, right, below the line. And all of the red centres, so the regional trauma centres, are more skewed towards the other end, so above the line. What that means is that the odds ratio of dying, if you went to a major trauma centre versus a regional trauma centre, was 0.6. So there was a significant mortality improvement if a patient was treated at a major trauma centre. So that informed us when we were working on the system, in that overall the system is performing well. The definitive care at a major trauma centre was associated with a lower likelihood of death, which meant that we should concentrate on improving the care provided at our regional trauma centres. And so that led to this improving the quality of trauma care document, the trauma services model of care. You may be familiar with the Gold Book, which is the American College of Surgeons requirements for their trauma verification. We have a very similar trauma verification program of trauma centres, right? So this is looking at the criteria that are required to become an effective trauma centre. And this trauma verification was utilised to improve the care. The regional trauma centres were identified as the key priority, and the verification of the hospitals occurred within the referral networks. And we've almost essentially completed that. So that started a couple of years ago. All of the trauma centres in New South Wales and the state have now nearly been verified, or at least gone through the process. The other aspect to the system improvement that we learned is that I think knowing your mechanisms can help inform prevention. And this is what I meant by if you've got the data and the outcomes, you know then what you can target. And so you can see here, the blue line, it falls. We've got a lot more falls now than road traffic crashes, right? We don't have gunshot wounds, so our assault is very low, but the falls are a big deal. And so again, we had from the state perspective published as in some epidemiological data about falls from ladders in New South Wales, and that was a data linkage study. And then there was also this falls prevention paper that was done, because again, what we know is similar to what Priya was talking about in the previous talk, is that the older patients have falls from standing height. And so a big prevention piece is how do we prevent those falls, because they make up now a significant proportion of the trauma work that is done in our hospitals. There are some other examples of change that we've had from the evolution of our trauma system and the ability to actually evaluate outcomes. So we've heard and you've seen this diagram about the patient from the place of injury. How do they get to the major trauma centre? How do they which ones do you choose to go to the regional trauma centre? Which ones can go to your local hospital? Right? And so this is this T1 protocol that I mentioned earlier, which is our state ambulance bypass protocol. And so there are criteria based off the mechanism, the injuries, the signs and symptoms, and then the transport. And so based off those, if they satisfy the criteria, that patient can have up to 60 minutes of transport time, be it by road, be it by helicopter. So they can fly by helicopter over several hospitals to actually reach the major trauma centre. And so this has been in place now for over 10 years. And part of that process also is what we call the Rapid Launch Trauma Coordinator. So we have an ambulance control centre that's staffed 24 hours a day, right? It's separate from every hospital. It's part of the ambulance service. There is a person that is assigned to be the Rapid Launch Trauma Coordinator who monitors all of the emergency calls. In Australia, we have 000, so in America it's 911, and looks at the information that comes up to determine if they need to send, for example, our pre-hospital retrieval physicians via helicopter, via road, to provide higher level care. So they're monitoring the calls and the incidents as they come in. And so again, that's part of the system that's there that allows early effective treatment of the patient and then transport of the patient after initial care to the appropriate centre. When we looked at the ambulance road transports for trauma in New South Wales, an interesting thing is that more than 90% of our bypass, our T1 protocols, occurred within our geographical area. So New South Wales is split up into, and Sydney is split up into sort of defined geographical areas. And so each area within that geographical system has maybe 3 or 4 other hospitals sort of within about maybe half an hour to their major trauma centre. And so actually most of the injuries and the bypasses occur within that geographical area, which kind of makes sense because we know that patients are more likely to be injured near their place of residence rather than elsewhere. As part of ITEM, which has overview of the state system. There's a clinical review committee, and one of the things that we did when I was the chair of that committee was that we found that there was a delay to definitive hemorrhage control. Right? That was an issue that was coming up when we looked at the deaths that were coming in from a statewide basis. And that came down to a lack of senior decision making and then also surgical expertise. So we came up with a pathway, a document for what's called a Trauma Code Crimson pathway. And really what it is that it's a process that allows early notification that this patient is bleeding and requires urgent hemorrhage control. That means that basically you're turning the system on early. So for us, because there's not very many hospitals that have in-house trauma surgeons, particularly after hours, this means that if a Code Crimson is activated before the patient arrives, that on-call surgeon will start making his or her way into the hospital at that notification. So not waiting for the registrar or the fellow to make an assessment and then call. This is an early notification. It means the operating theatres are notified, means the blood bank is notified. So this is a process that was that was thought through about how to turn the system on early. Another project that we undertook is that we published this study looking at the optimal access and configuration of trauma centre care within our state. And this is an example of what you can do when you've got a developed system. Right? You start looking for ways that you can improve it, right? I wouldn't suggest doing this at the very beginning. So we're at the point now where we look at our centres and we go, do we need all of them, right? It's a bit like what Mark Fitzgerald talked about in his presentation this morning. Victoria has 2 trauma centres, adult trauma centres. In Sydney we have 6, right? So we kind of looked at this using GIS. You can see the population. The heat map shows that the vast majority of the population lives within Sydney. The potential access to the trauma centre by ground transport, when we used the GIS mapping and looked at the road, traffic conditions, the timing and the like, is that basically you can see that 91% of New South Wales population has access to a major trauma centre or a regional trauma centre within 90 minutes, and 78% to a major trauma centre. And more like 65% actually have access within 30 minutes by ground transport. If you look at these heat maps, really what's important is that the darker and further out that it is, that's sort of within 90 minutes, right? And everything outside that means that it's going to take longer than 90 minutes to actually get to a trauma centre. But you can see around the major clusters or the major cities that you can actually get to most of the hospitals, a regional trauma centre. Certainly along the coast you can get there easily, but as you go inland it gets more and more difficult. And this is a reflection of the population. When you consider the helicopter, it covers even more, but still you can see there's a big chunk that isn't coloured at all, right? And so what we learned is that 0.8% of the population doesn't have access to trauma centre care within 60 minutes. But that 0.8% lives in 48% of the land square area. So it's like little dots of people, right? Which then begs the question, well, how do we improve equity of care, right? Because you've got to give up something. So if you say, well, we should try and make sure that these regional people have access to trauma centre care, that means you're going to have to give up something, right? But this is things that you can only do if you've got data and that you can look at it. And if we reduce, as in the number of trauma centres in Metro Sydney from 6 to 4, you would have only a 0.5% reduction in the population that wouldn't be able to access a trauma centre within 15 minutes, right? There was no change in access for 30, 45 or 60 minutes, right? When we looked at that. There would be a subsequent increase in population coverage sort of for the 60 minutes as per our T1 protocol. So a couple of the centres would increase the population that they would have to cover by up to 47% for that. But it just showed that there is data that can be used to inform our location and designation of trauma centres. So in summary, I guess a mature trauma system can be achieved on a state level with a focused leadership or institute. So like as in that's what ITEM is, which provides oversight and direction for the state system. There are opportunities to continue improving the system. There are always future issues to consider, particularly for us. It's how to address those inequities in the regional areas of our state, right? Like how do you improve the care in regional trauma centres? Do we need more regional trauma centres? We have an older population that are injured predominantly because of falls, and so that is a big problem, and that for us, again, that's a problem that's going to get worse as we progress, because the population everywhere in Australia is getting older. And then I guess the other future issue is about how do we rationalise our trauma centres within metropolitan Sydney. So with that, I'll close, and thank you very much for your attention. Thank you for hanging around, and please, if anybody has any questions, I'm happy to answer them. If anybody wants to contact me, those are my details. Very happy to entertain any questions or inquiries. So thank you again.
Thank you, Prof. Jeremy, for excellent presentation. Any questions? Open for the audience. So in absence of any questions, I would like to add on something special now. You said about 0.8% of the population doesn't have access to major trauma care centers within 60 minutes, that means 1 hour. Yeah, that's a very good eye-opener for even our policymakers. They are trying to put young budding surgeons into the depth and the breadth of the country, where a small percentage of population without any facilities. What they need to improve is the transportation and multiply the number of surgeons in a major center. Yeah, that's a good eye-opener actually. That's very good, excellent. Thank you very much.
I think that's, hopefully there's a lot of stuff that can be translated into, say for example, the local system, and how you manage it has to be thought of carefully in the context of what is available, because again, it's expensive. Like say for example, if you said, right, well, we can improve it by having 5 helicopters. You have to invest in 5 helicopters. But maybe that's cheaper than putting 10 surgeons and CT scanner in those hospitals. So I think that it's a really important conversation and thought that has to be, basically pursued to work out what the best is. And that's why I think these sorts of meetings are fantastic, because you get to see like what are the things like, what other places are doing and how you might manage that problem.
The other things you said that while answering the patient to bypass hospitals and go to the trauma center. All the trauma patients are only selective patients.
Yeah, it's a great question. I think we have refined our bypass system into only select patients. So patients that are showing physiological signs of severe injury or injury patterns that are severe, they will then be transported bypassing local hospitals. I think a great example of it, certainly from a local perspective, our observation from last year is that we were very fortunate and privileged to visit hospitals in Balapitia and Elapitia. And we were amazed that they don't have a CT scan right there. But patients who had potential head injury, so pedestrians hit by car, motorcycle crashes, were still taken to those base hospitals and then were assessed, and they're very well assessed, but then had to be sent to Karapitia, I think, which has the CT scanner, to then have their assessment done. which, you know, like again, like to me, this is the sort of the pre-hospital system implementation or a potential intervention that can actually change the outcomes, right? It's a very simple tool, right, if you're able to, because instead of taking the patient to a hospital that can't actually evaluate them appropriately, identify them at the site of injury and then transport them straight to the hospital where they're going to end up anyway. Like, so I think that's the key. It's actually being selective. It's not all. So
Basically, the pre-hospital team is mainly deciding on the basis of the guideline.
yeah.
Thank you.